Idaho Matters podcast is brought to you by St. Luke's On-Demand Virtual Care, which allows patients to see a provider from their home using a computer or smartphone with on-demand care for common ailments, such as a cough, sore throat, or a sinus issue. More information at stlukesonline.org.
The West is in a snow drought, mountain areas delayed opening, and limited ski runs. But nonprofit recreation area Bogus Basin has a secret weapon against the warming conditions.
I talked to the snowmakers and I was like, just start making snow up there. And we picked a spot. We called it Project X. We just made a giant pile of snow.
I'm Jamie Geary. How Bogus Basin opened with snow stored last season. Listen on BoiseStatePublicRadio.org.
From the studios of Boise State Public Radio News, I'm Gemma Gaudet. This is Idaho Matters. Recent comments from the new chair of the CDC's Vaccine Advisory Committee have sparked sharp reaction after he questioned whether long-standing vaccine recommendations, including for polio and measles, should still be broadly applied or left to individual decision-making between patients and doctors. Now, supporters say it's about restoring autonomy and trust. Critics say it misunderstands both the science and the history of infectious disease. Well, since it's Wednesday, that means Dr. David Pate, the former CEO of St. Luke's Health System and the co-author of the book, Preparing for the Next Global Outbreak, is joining us to talk more about this. Hi, Dr. Pate.
Hi, Gemma.
And folks, remember, if you have a public health question, be sure to send us an email, idahomatters@boisestate.edu. And we do have quite a few questions from listeners to get to today. But before we do that, Dr. Pate, you have recently written 2 blog posts about these comments from the new chair of the CDC's Vaccine Advisory Committee. I'm curious, when you hear a senior vaccine advisor question whether we still need broad recommendations for vaccines like polio, what concerns does that raise for you?
That caused me true alarm. Up till now, obviously, you and I have discussed on many occasions misinformation about vaccines, disinformation about vaccines, bad decisions being made at the HHS level or CDC level in this current administration. Those are things that are concerning. The talk about polio vaccine is alarming. If polio vaccine goes, then everything goes, because what people that aren't as old as me or older probably don't know or have forgotten is that there was an actual panic in the United States in the 50s about polio. Parents were very worried about their children. We're not letting them go to public pools. We're very fearful that they might contract polio. And as my mom would tell me, when she would go to the movie theater, the preview was a public health announcement about polio when the vaccine first came out, encouraging people to get vaccinated and showing the people, the children and adults in iron lungs, the people, the children getting fitted for braces because they had lost use of one leg. And so it was a real threat back then. We haven't dealt with that threat to any sizable degree because the vaccines came out. They have been very, very safe, very, very effective. And this is one of the diseases that we actually eliminated from the United States. Now, if we were to stop vaccinating, we know that virus is out there because there are 2 countries in the world where polio in its wild form circulates. And that's because they cannot maintain sufficient vaccination status. That's Afghanistan and Pakistan. If we were to stop offering or requiring polio vaccine, we would be the 3rd country. Imagine that. The country that has been the leader of public health will now be relegated to one of the three worst performing countries in the world.
So, Dr. Pate, the argument that we're hearing is that improved sanitation, as well as modern hospitals, better intensive care, are changing the risk calculation for childhood diseases. From a medical standpoint, does better treatment meaningfully replace prevention when it comes to illnesses like measles and polio?
No, and the reason is that in all of these decades we don't have any new treatments. When this doctor, who by the way, it's just I said in my blog post, because I know he knows better. He is a pediatrician by training, for heaven's sakes. So what I said in my book, I cannot ascribe this to ignorance or just the fact that he doesn't understand viruses or diseases or vaccine. This is evil. So to clarify on this, there are no new treatments. When he was asked about it, you know what he says the new treatments are? We now have pediatric hospitals and pediatric ICUs. Really? Because we have hospitals, now we can let kids get infected? What parent out there wants their child to end up in pediatric ICU? That is just a ludicrous statement. And what we have to keep in mind is we're seeing today, if you have any question about whether vaccines work and what are the consequences when you stop using them, look at the measles outbreak. We have a measles outbreak that's been ongoing for a year now in the United States, and it's growing. South Carolina just became the highest number of cases, even though this outbreak started in Texas. So if you want evidence, there you go. We are now having measles, and we are having people die of measles that have it for decades. And so that's what we're dealing with. Now, if we stop polio, what you're going to be talking about is we will have 10 to 15 times as many people as died with measles will become permanently paralyzed. And this doctor who made this terribly ignorant or evil statement, all he has to do is look to a 23-year-old man in New York who traveled internationally, wasn't vaccinated, got polio. That man is paralyzed. And that is what we're talking about doing to our children, committing them to a life of weakness or a life of paralysis. Really?
So, Dr. Pate, there are claims also that vaccines have not adequately been studied for safety and that existing monitoring systems are weak. So, how accurate is that characterization of how vaccine safety is evaluated in the United States?
Those kind of comments are just being repeated and repeated by people that don't have any knowledge. The sad thing is those kind of statements are being put out there by people with lots of social media influence who actually do know that's not true, but then it gets picked up and amplified. So let's talk about that. First of all, one of the complaints is, oh, well, these vaccines were never tested against placebo. That's wrong. And there are sites you can go to where they have compilated more than 160 studies that show that every one of these vaccines was tested against placebo initially. Or when a new vaccine came out, we compared it against the previous vaccine. It would be unethical to compare to a vaccine that works and not offer it to people. So that's wrong. Number two, on the safety monitoring, we picked up a problem with the J&J COVID vaccine back in 2021, when I believe there were 4 deaths out out of all of that, it was like 4 people died, and we already had that was enough. Our vaccine safety monitoring systems picked it up, told us, hey, pause the use of this vaccine. There's something out of whack here, and they determined what was going on. It was still a very rare complication, because by that time, I think hundreds of thousands of people had been vaccinated, but we picked it up very, very early. And we have more examples where our monitoring systems do pick up these vaccine signals very quickly.
So, Dr. Pate, I want to turn now to the measles, as we've mentioned briefly, because I believe earlier this week, late last week, there were 2 confirmed cases of measles in a middle schooler and a high schooler in Caldwell. They're siblings. We've been told by health officials they're both unvaccinated. I believe at least one of them was exposed during travel outside of the state over the holidays. All of the confirmed measles cases in Idaho so far, according to health officials, involve unvaccinated or unknown vaccine status. So what does that tell us about where prevention efforts should be focused right now in regards to Idaho?
Yes. So as you and I discussed, it was only a matter of time before we would have outbreaks of measles here in Idaho. We know that there are not sufficiently high immunization rates here in Idaho. And we know that neighboring states were already seeing measles outbreaks. So it was just a matter of time. Here we are. And if you look at the now, I believe there's 16 cases confirmed now. The majority of these are 5 to 12. Why are we seeing that? Because they're school age. And when you go to school, then the children that are unvaccinated are going to be exposed to these children with measles even before they realize that they have measles. And as we've talked about before, measles is one of the most communicable, transmissible, infectious viruses that we know of. And if you are in a school, particularly in a classroom with somebody that has measles, even if they don't know it and you're not vaccinated, there's at least a 90% chance you're going to get infected. And we know this virus can hang around in the air when somebody, like one of these 2 students, has been in a room. It can be detected in the air for up to an hour or 2 after they leave the room. So you may not even know that there was another person in the room that may have had the measles. So this is very transmissible. What this tells me is sit tight. There will be more cases, because once this starts getting to these kind of numbers, especially when you've got cases outside of one family, because it's so infectious, it's not surprising that brothers would infect each other. But once you start getting other family members, as we are seeing now, it will start circulating more broadly in the community. So if your child is not vaccinated, please talk to your doctor about getting the child vaccinated if they're eligible. If you have a toddler or an infant who has not yet been eligible to get vaccinated or to receive the full series, please be careful out there, because your child could be exposed in public areas. Talk to your pediatrician, monitor your child, and let them know at the first sign of symptoms.
So, Dr. Pate, Idaho health officials are now saying that schools can no longer rely on vaccine requirements. So they need now to focus instead on things like hygiene and ventilation and symptom monitoring. Are those measures, in your opinion, enough to stop measles transmission in a school setting?
No, not with measles, as infectious as it is. Now, we could cut down on a whole host of respiratory virus illnesses, particularly in the fall and winter months, if we would improve the air quality in schools, the air filtration, the circulation rates. There's lots we could do, and it would definitely decrease school absenteeism. It would decrease circulating other diseases that we're dealing with. Right now. We're having a lot of mycoplasma pneumonia in schools. It certainly helps reduce flu transmission, COVID transmission. So I'm not saying don't do it. Absolutely do that and improve. But you're not going to get out of measles outbreaks by washing your hands and improving ventilation. And it's just all too convenient to give up on vaccines. We have got to revisit this, and we are going to see how this plays out with all the changes that we've made here in Idaho to make it even easier for children not to be vaccinated. The children are going to pay a price.
So, Dr. Pate, there's some new research that's adding to a growing body of evidence that alcohol does more than affect the liver. A large study was just published this week, and it finds that long-term heavy drinking is linked to a significantly higher risk of colorectal but especially rectal cancer, even as cases, as we know, continue to rise among younger adults. Now, the findings are also suggesting that cutting back or quitting may lower some precancer risks. So, the studies suggest that it's that cumulative effect of drinking over decades matters more than like short periods of heavy use. So, how should people think differently about alcohol and cancer risk over the course of a lifetime?
Yeah, I think that what I see is more and more emerging evidence that the benefits of alcohol may be way overstated, and that really the benefit to risk ratio is probably far worse than what we had previously thought. I think that field is going to continue to give us more and more information, and we'll get clearer about it. But I think what we can say from this study is there is an association, there is an increased risk of colorectal cancer, and particularly, as you mentioned, rectal cancer, which can be even more problematic in many cases, that is associated with cumulative alcohol consumption. The good news is that cutting way back on alcohol or abstaining from alcohol can, over time, reduce that risk that you've accumulated. And so what they saw is if it was if they compared a group that drank less than one drink per week, one or less drinks per week, with those that drank 14 drinks per week or more, there was a 25% difference in risk,
Wow.
and the more that you drank, it went up, and it was double that for the rectal cancer. They also, like you were talking about, in heavy use that is over many years, that risk appears for colorectal cancer to increase by 91%. So you are almost doubling your risk of getting colorectal cancer if you have a lifetime of heavy drinking, especially if it's consistently, not just binge here and there, but you're doing this all the time. And as we mentioned, conversely, if you discontinue the alcohol with time, that risk continues to decrease.
So, on top of that, fewer than 70% of eligible adults are actually getting screened for colorectal cancer in the US. So, how dangerous is it for people to delay screening? I mean, especially maybe if they have risk factors like heavy alcohol use, as we're finding.
So, colorectal cancer is one of the few cancers that this screening can essentially ensure you won't get cancer, because we can identify a precancerous stage, and that can be easily remedied. So we know that most colon cancers go through a process where you develop polyps first. And these are like if you think about if you're looking in your throat and you look in the back and you see that hangy down thing, we call it the uvula, but all my grandkids call it the hangy down thing. That if you saw that hangy down thing, but it was in your colon, that would be a polyp. And and those with time, and it takes years, but with time, certain types of those can turn into cancer. When we do a colon screening, a colonoscopy, the doctor can see those. We can actually, with the same instrument they're screening you with, they can remove that polyp. You don't even feel it. You won't know that happened. And there's no extra recovery time because of it, but they can remove it. And with removing that eliminates the cancer risk from that polyp. Now, because you develop polyps, then you need to be screened in future years. But this is a screening that can almost ensure that you will not get colon cancer if you do it as recommended.
So I want to get to some listener questions now, Dr. Pape, because we had quite a few come in this week. So Philip wrote in, and he says specialist physicians are often in short supply in more rural locations like Boise or other Idaho cities. What have healthcare institutions done to make sure there are well-practiced specialists in every field? He goes on to say durable medical equipment is not a substitute for clinical expertise and experience. So how are major healthcare providers in Idaho making sure there are quality providers available to Idaho residents or available and accessible by transport?
Well, our healthcare organizations in this state are doing the heavy lifting. They are recruiting, they're trying to recruit physicians from around the country. Now, physicians have lots of choices where to go because there's shortages in almost every state, particularly for some of those specialties. But our healthcare organizations are recruiting. When I led St. Luke's, we were recruiting all the time and spending a lot of money to do that. The second thing is that organizations around the state are also serving as training sites for medical students and medical residents, because if we can train medical student graduates as they're doing their residency training, we greatly increase the chances that they will stay in Idaho to practice. And then the other thing we're doing, because we just can't keep up with the demand, is we're using virtual care to allow specialists, for example, that we might be able to recruit to Boise, but we can't recruit to another part of the state. They can provide a virtual care that way. But people should understand all of this is connected. So when we are having measles outbreaks like we're having, when we are having laws put in place that threaten to put obstetricians in jail for making a decision that is touch and go to save a mother's life who's pregnant, when we have these freedom laws and so forth, which I'm all for freedom, but I'm also for some responsibility. Remember, doctors have kids. And let me tell you, even the anti-vaxxers that I know of, their kids have been vaccinated. So they're trying to convince you not to, but they're getting their kids vaccinated. And so, but they're not going to want to put their kids in schools that are going to have measles outbreaks today and maybe polio outbreaks in a few years. So it makes it harder when the culture is getting more and more anti-physician, anti-medicine, anti-science. And this is being fueled a lot by our legislature. And I keep trying to tell them, you're complaining about the physician shortage and you're talking about these things you want to do, but you're at the same time, you're fueling the fire. And so we have to remember that. The other thing is that when you recruit physicians, a lot of times their spouse is a professional. So not only do we have to have a job for the one spouse that's the doctor, but we have to be able to find a job for the other spouse or they're not going to come here. So it's much easier than it sounds. I applaud the healthcare organizations of Idaho for the hard work and all the money they're investing to try to solve this problem, but it's being thwarted by what our political and ideological decisions are, and we need to keep that in mind.
So Shane wants to know, he says, I was hoping Dr. Pate could talk about the Nipah virus this week. And I have no idea what that is, Dr. Pate.
Well, and you don't want to know. The Nipah virus is a very nasty virus. And this is a virus that so far, and I'm knocking on wood over here, has not made it to the United States except it got to the Philippines. But the high risk areas for this virus are in Bangladesh and in India. And right now there's an outbreak in the state of Kerala in India. And what this is a virus that's transmitted by fruit bats. And so the fruit bat nibbles on fruit. Imagine that. And when it does, it injects the virus in its saliva into the fruit, but a bat isn't going to complete the fruit. So the fruit drops to the ground. And then what happens is humans or pigs come into contact with that fruit. And that's the most common way they get infected. Once infected, humans can spread it to humans and pigs can spread it to humans. And so we oftentimes see this occur in pig farmers as one of our first signs a lot of times. This is a virus that could easily, we have millions of people from India that come to the United States, and so it could easily be transmitted here. And again, we have to remember all of this stuff is interconnected. Well, guess what? If it did, I think everyone in our epidemic intelligence service has been let go of their jobs. So we couldn't look to the CDC to help us with investigating and containing this. So then, then we would contact the World Health Organization, but oops, we just exited the World Health Organization earlier this week, so we aren't going to get help from them. So this will fall on state health departments if we ever were to get a case and some spread here in the United States, meaning that, especially because they don't have the expertise and the staff for this, we are very vulnerable to this virus and many other viruses of entering into the United States. I remember the day when we thought, that would never be a problem. And we thought about Ebola. It's not going to be in the United States. It showed up in Dallas. And guess who gets infected? Our healthcare workers get infected.
Okay, well, speaking of the World Health Organization, Sue wrote in and she says this. The WHO says Marburg virus is done in Ethiopia. Dr. Pate, can you talk about this disease and should we be worried about it? It looks like it has a really high fatality rate.
It does indeed. The mortality rate in this current outbreak that is just ending in Ethiopia has been somewhere between 64 and 74% of cases have died. Like the virus we were just talking about, the Nipah virus, and with Nipah, 60 to 90% of people die. This one's, right around in that 3/4 of the people will die. These are very serious threats. Now, they're not the same kind of spread as a threat as an influenza virus or coronavirus that could spread much more widely, but it is a threat. And what we have to be concerned about in both cases, Nipah and Marburg, we don't have vaccines. We don't have any treatments. It would just require, good supportive treatment. And again, we're all interconnected. This virus, the Marburg virus, is also transmitted by fruit bats. Now, the kind of fruit bat that transmits Nipah and Marburg is we have fruit bats here in the United States, lots of them, but we don't have that particular species. I don't know whether our fruit bats could become infected with this virus, or if it would have to be that particular species. I don't know the answer to that, but we don't want to get it introduced in the United States and find out. So these are both serious. And again, we would be equally unprepared to address either.
Dr. Pate, I've got about 2 minutes left with you, and I want to talk quickly about the fact that on Monday's show, we looked at migraine headaches, and the BBC actually just came out with a new look at what really causes these debilitating headaches. In the time we have left, can we look at the genetic origin of migraines and this idea of blood versus brain?
Yeah, we are constantly learning more about migraines. Migraines have been an enigma for so long as to what causes them, and we still don't have a perfectly clear answer. But what we have learned is, just as you said, there is a genetic component. Now, that's not in every case, but it probably maybe 30 to 60% of cases could be ascribed to genetic predisposition. And we do know that these can certainly tend to run in families. The other thing is we're starting to learn a lot more about how migraines occur, which is giving us some new potential treatment options, because it typically starts as an electrical change across the brain. And we've now identified a peptide, a piece of a protein that might be associated. There's a promising story, a study that was done last year, but stay tuned, because we may have far more effective treatments, and we're getting a better understanding of this disease all the time.
Well, as always, Dr. Pate, we so appreciate you. We've been talking with Dr. David Pate, former CEO of St. Luke's Health System and the co-author of the book, Preparing for the Next Global Outbreak. And if you have a public health question for Dr. Pate, send us an email, idahomatters@boisestate.edu. You've been listening to Idaho Matters from Boise State Public Radio. I'm Gemma Gaudet.
Hey, I'm Peter Pruitt from Zoo Idaho.
And I'm Dr. Leif Tapinola with the Idaho Museum of Natural History.
Together we host The Nature of Idaho, a podcast all about how our state's amazing landscapes, wildlife, and geology shape life here in the Gem State.
Each week we dive into nature stories from across Idaho, everything from fossils to forests, and sometimes even a few fun facts you can share on your next hike.
So join us as we celebrate everything that makes wild Idaho special.
Listen to The Nature of Idaho from KISU, wherever you get your podcasts, or at KISU.org.